Hello, hello. How we doing today? Exactly. It would be amiss if I didn't open the sex work conference in that way, right? So let's see. I'm gonna get us set up here, but thank you so much for having me. I am incredibly happy to just be here, see you all, and to be part of such a historic moment. Sex workers are a big part of the reason I became a sex educator, from porn performers to movies where a stripper falls in love. Like, it's just always a part of the fabric of the culture. So I think there's credit there. Let's see, does this work? Yay! Okay. So yes, as I was saying, thank you all for being here today. On a serious note, this is very important to me as someone who's both studied this and also just have so many just personal experiences from my early career as a sex educator working with sex workers. I am Birna Gústafsson, as you heard. Also, can you hear me okay? Everything? Cool. I'm an educator and a public health advocate. I've been a sex educator for about a decade now. Ooh. Wow, sounds weird. But yes, over a decade. And a couple years ago, I made a transition into public health, but I still work in sex ed. I work more in university settings now. But the public health aspect of it is because I kept getting asked the same questions over and over. And I realized, sex ed is really, it's a public health issue too. I currently live in the US. I'm born and raised in New York, but I'm also Icelandic, so you might hear me speak both languages today. And I currently live over there, but I work in Iceland in the spring. So I'm going to be showing you a little bit of what I do here in Iceland. I'm a co-instructor of a course for sexuality and clinical practice for nurses and midwives here at the University of Iceland in partnership with the University of Akureyri. And part of that is that we do discuss sex work, whether it's something I bring up on purpose or something that just emerges, because it is a part of the fabric of healthcare, especially for nurses. And in general, sexuality topics are very divisive. We know that. But add in these discussions about exploitation, commodification, objectification, feminist theory, academically and when you're talking on the couch with your friends, right? Ethical conundrums. It can lead to some very intense and heavy discussions. So I just want to take a moment to recognize how incredible it is to have a group of people here who care deeply about this work and these workers. And they're willing to have these discussions because they care about the well-being of sex workers. So even if we disagree on specific policy or have different opinions about how to carry that out, I do think that there's a shared care and understanding, and I see that in my work in healthcare. And so also thank you to sex workers who share their experiences, their stories, and their recommendations, because you make work like mine possible. So sex work is perhaps so divisive, not just because it's, an icky feeling for a lot of people, because it also lives at the intersection of so many social determinants and identifiers. Because as an industry, it kind of sits at this crossroads, right? And if we want to use this metaphor from Kimberly Crenshaw, right? You guys have heard this before, of intersectionality, I'm sure. It's at the intersection of economic status, so poverty, class, and self-sufficiency. Gender identity, so we see things like assigned sex at birth, right? Sexism, transphobia, gender-based violence. Sexual orientation, we hear things like gay for pay, like homophobia, more targeted towards people of different sexual orientations. But also sexual violence, right? Heteronormativity, gender scripts. I'm entitled to this, you owe me this. Things like that come up as well, right? Immigration status, especially for those who are undocumented, migrants, but also work permissions. How do we facilitate work permissions in an industry that is so difficult to define? Race and nationality, right? Racism, bias about nationality, and also division amongst ethnic groups. And then sexual expression, slut shaming, regardless of your status as a sex worker or not, right? That's just one of those intersections. How sexually expressive are you? But also reputationally, what precedes you, what follows you. So even if you leave the industry, that's something that follows you, right? So these are not all social determinants or identifiers, but they're kind of a mix of both. But the most marginalized workers are at multiple intersections, right? Where I'm from in the US, especially in New York, we see Black trans workers being extremely marginalized and most marginalized. And so as a result, they are often dealing with a type of violence that is different than other types of workers, especially street-based Black trans workers. How do you tackle a problem like that, right? There's transphobia, there's racism, there's sexism. You can't really tackle it just with one black and white policy, right? It also touches on hot topics such as kink and fetish. Is BDSM inherently abusive? That's something we hear all the time, right? Bodily autonomy. Are they selling access to their bodies? Does monetization impact their consent? Gender disparities. Are we allowing women to be easily commodified? This is something we hear a lot too, right? And labor rights. What protections could sex workers receive under Nordic economic systems? I bring these up because I think it really highlights why the research is often difficult to carry out in terms of what we call reflexivity of the researcher. So it's like you have an internal bias. So when you're having interviews with sex workers, what's coming through? How is it, how you're showing up that day, how is that presenting itself in the research, right? But also arguments between policymakers, because these are very inherent value system moral positionings, right? These are just questions, but how you tackle these questions can really impact the way a policy changes and moves. Economists also, gender theorists, healthcare professionals, what are we bringing into the conversation? Which of these questions do we tend to divert towards, right? Because sex work is not a black and white issue. None of these things are, right? And as a result, it tends to bring up a lot of side discussions, a lot of tangents when we discuss it. So when I teach about sex work in healthcare, and when I teach healthcare workers who have a lot of questions about it, a lot of these things come up, which is natural. But when we go through our case studies today, you're gonna see some of this as well. And a lot of people are just processing. I've been told it's been wrong. I've been taught it's been, it's abusive, it's bad. These are questions people should be asking, and the facilitating of discussions, I think, is really important for us to move the needle, right? So when we discuss sex work policy and public health, I want us to think about it in two ways, right? And here you get to see my little health economics nerd side come out. So macro and micro, right? Public health and safety as a large-scale monitoring, implementation, and communications field. Just fancy way of saying, when you zoom out, what are people up to? How are they feeling? How many STIs are going around? Stuff like that, right? But on the micro level, this is often forgotten. Healthcare seeking. How likely is a sex worker, how likely are they to want to go and receive healthcare? Have they been shamed in the past? Did someone see their advertisement and so they're like, I know what you are. You're gonna just come in here for STI testing. Stuff like that, right? How does that impact not just their health and the healthcare access, but their healthcare seeking behavior? Patient communication, how are we speaking to patients? What are we speaking about? What do we need to include in conversations for people who disclose their sex work status? Education, so that means patient education, and healthcare access, of course. So these are the two things I want us to focus on, because the other discussions are important. They come up no matter how much I'm like, stay on topic, we're here for healthcare. They're like, no, let's talk about BDSM, all right? I'm like, okay, can we do that later maybe? But it's important to acknowledge the realities of sex work in public health regardless of the discourse that comes up around it. So I teach sexual education to healthcare workers, as you're probably aware of now, both in terms of comprehensive sexual education for the healthcare provider and instruction and practicum on patient education about sex education. So it's not just about like what they know, like they know how a condom works and all that stuff, but it's also tools to teach patients, because sometimes you know the sex education, but you can't really translate it to others, and that's a key part of it here. So before I dive into the policy and the research-heavy kind of side of things here today, I want to do a little exercise independently, which I do with my students. So I teach nurses and midwives, and at the end of the semester, we do a practicum. We do a little discussion seminar. So it's very old school. I make a little sheet of paper. I'm literally there with like scissors, like cutting them out and handing them out to every person. I teach about a group of 70 or 80, so we split them up into 4 groups. Everybody gets their own sheet of paper with a case study that I have created, and some were about sex work, and some are about adjacent topics to sex work. Some are like, could this be a sex worker? And it's an independent activity. First, I make them journal, and then I make them talk in small groups. Then they pick one of the case studies to discuss as a small group, and then we discuss. So it's like different types of learners get their stuff. We're not going to do it all as a class today, but I just want to give you context. So this is like the journaling exercise I give them, which is just like what's coming up for you. Because the point of it is not just to do a practicum, which is like, what have you learned and how are you putting it into clinical practice? It's also, how are you feeling about it? Do you feel weird? What's your attitude about it? Are you lost? Are you confused? Are you excited to work on something like this? How well do you understand it? It's making them aware and observe like where their gaps are in their knowledge, and also it helps me because I'm like, okay, none of them know how to tackle this. Like, how do we implement that next year? And then in the little groups, we talk about more like solution-oriented stuff, like what's related to it. I'm making them like identify and observe what is like some of the stuff that you've learned this semester. Can you like name some of the stuff that's coming up in here? So I'm going to do one of these case studies right now. I'll read it out loud like I do in class. So the title is Bartholin's Cyst and Frequent Sexual Activity. And if you don't know what a Bartholin's cyst is, don't worry about it. It's not that important. It's just like a cyst on the outside of the vulva, on this little gland called the Bartholin's gland, which is actually responsible for vaginal and vulva arousal fluid. Yay, we learned something. Look at that. Woo, anatomy. So a woman presents with a painful lump near her vaginal opening. She explains that it has been there for a few days, causing discomfort during sex. When diagnosed with a Bartholin's cyst, she asks, is there any way I can still have sex, or at least make it less painful? She adds, I can't really take time off from sex for more than a few days. What's the quickest way to recover? Another nurse tells you out in the hallway that they suspect the patient is a sex worker. While she does not explicitly disclose it, she may be a sex worker, though she could just happen to have a high frequency of new partners. So this is one of the case studies, right, where they get, and I specifically word it so it's a little bit like what do I do next? I kind of have a like cliffhanger because I don't want to point them in either direction. So it's not just that like this person is like, oh my God, I can't stop having sex, and they're like panicking, which you're kind of like, what's that about? But also, another healthcare worker is making an assumption here. Why is that? Do they know something? Is it a good thing that they know this? Is it a bad thing? Like, you know, how do we acknowledge that? So here's some of my student reactions. How does she know that she's a sex worker? Is she judging her appearance? What would change in our protocol or patient communication if she were? Which, when you hear that question, you're like, yeah, like nothing. But remember, if someone is a sex worker, maybe they do require a different patient communication because they require different resources. They would thrive under a different patient education model. It's not always a bad thing to differentiate, right? I'm worried that she can't take time off to heal. It makes me fear that she's being exploited, which is like a very common theme here. Well, she didn't disclose it, so we can't really assume, right? Unless there is a possibility that maybe she has seen her advertisement or maybe she received a service herself. This was really creative. I was like, that's true. Like maybe she knows because she knows this person, but she can't tell you that because of patient confidentiality. But is it her place to disclose that? What if she can't take time off sex not because she's a sex worker, but because she just uses sex compulsively to cope with stress? So it's like, wait, why are we making that assumption anyway? Like, does it change why we know that information or how we know that information? Are we pathologizing her sexual behavior? So these are the reactions, right? And I let them have them because it's important to be able to differentiate, like, the care to the patient, being able to put that stuff aside and be like, what does this patient need from me and how am I showing up in that work? But also just be able to speak up and process with your peers. If this were to happen, like what kind of reactions would you have afterwards, you know? So I want to leave you with that while we go into some of the other stuff here. But do we have to report if she is one? We can't really just ask her, so should we just ask about how many new partners? It's a lot of questions about like what's allowed, right? What if we say the wrong thing and then she doesn't come back if it gets infected? It's a big responsibility, right? That's a big one. I was like, yeah, like, I mean, that is a possibility. It's not a comfortable thing for healthcare providers and practitioners to accept and understand, but it's also this like enormous responsibility, right? It's like, well, is it our fault then if something happens? You know, stuff like that. So these are important things to process, right? So let's go into some of the definitions, because I think it's important to get on the same page, right? Because what counts and what doesn't? So the definition of sex work varies slightly depending on what organization or nation is defining it. So for the sake of my presentation today, we don't have to agree all together after I'm done talking, but just for the sake of my presentation today, I'm keeping it intentionally vague. So this is the exchange of sexual services, performances, or products for material compensation. I include performances here because it is a gray area, right? Is there touching? Is there genital touching? Is there porn performance? So that's like why performance is in there. So this may include physical contact or what's called indirect sexual stimulation, which is just a very interesting way of saying turning someone on intentionally. May include that, but also they're voluntary transactions, which sounds pretty straightforward, but it's admittedly difficult to define at times what is voluntary and what is not, especially when the definition of sex work includes things like sexual trade for housing, substances, food, because like so much of survival work that is not sex-oriented, the line between voluntary and exploitation is often blurred, right? And so does that count? Is that automatically in one category or the other if someone's not receiving cash, but maybe they're receiving rent? Is that exploitation? Is it not? You know, and so for the sake of today and for the sake of healthcare practice, I say, does it really matter? How we move forward and how we discuss sex work, you're not going to be able to know necessarily unless they disclose. So we have to treat everyone as if they deserve the same amount of patient education and communication regardless, right? So not all forms of sex work are illicit either. They're not all illegal, but they do all face a similar level of stigma with varying degrees. And when I say illegal, I mean as a provider or a client, because there are also forms of sex work that are illegal under end demand policy, right? And as clients, there's certain types that are not illegal to participate in, but they're still in a weird gray area. And that's important to keep in mind. And this picture here is from actually the New Zealand government public act here. So this is like a definition that is really interesting. They have this like Prostitution Reform Act of 2003, and then they kind of use the same document and they just keep like adding to it and like changing the definition up until they decriminalized. So from 2003 to 2018, it's like moved around a lot. And so it's interesting for me to see like what the goalpost kept moving a little bit, and also we kind of pushed the needle. And so it's like prostitution is specifically defined because it's still a legal term. Is that a term that we use in healthcare now? No, but the legal side does. So that's also a weird thing, right? If the legal side is using those terms and we're not, what's getting lost in communication? So what counts, what doesn't? Again, is physical contact required to categorize someone as a sex worker? Definition of voluntary transaction, like I was talking about. Does non-monetary compensation count as sex work? Does it count as something else? It is a secret third thing that we're not discussing. I don't know. When discussing ending demand, what demand in particular is being ended? Is it oral, vaginal, anal sex only? Like from a healthcare perspective, right? Then we have to like really hunker in and be like, we gotta look at the STI stats, we have to understand, contraceptive use. Is it manual stimulation, which is just a fancy way of saying a hand job? Like, is that included? Is it not? And these are important discussions. I know I'm like, making jokes here, but is someone who works in massage work and only does manual stimulation, what makes their patient needs different than someone who engages in what we call full service with perhaps oral, vaginal, or anal contact? And legally speaking, where's the line there? What does one person receive while the other person doesn't, and why? So you see these red umbrellas here, and all of you are aware, like it's an umbrella term. So what constitutes sex work? Also things like camming, chatting, phone sex, pornography performance. This is a form of sex work, right? Escorting, allowances, being a sugar baby. Is that a form of sex work? Legally and healthcare speaking, right? One-time payments. Full service, like I mentioned, versus street-based versus indoor. So when we look at research, which like I spend a lot of my time doing, when I look at this and I see these different definitions, right? I'm like, okay, so this person's saying indoor. Is that in calls or are they talking about brothels? Not very easily defined, right? Are they working like 3 girls in an apartment? Is that a brothel, legally speaking? Where's the line there, right? And when we look at these legal definitions and then compare them to the healthcare, there's a lot that's getting lost in translation. So how are these terms defined and used institutionally? How does it differ from how sex workers themselves use them and define them? There's a big kind of difference there sometimes as well. So when you're speaking to a patient and they say, well, yeah, I work at a legal brothel and blah, 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 and you're just like, okay, what does that mean? Like, where's the line there? What do they need from me in terms of how does that impact the way that we move forward in a discussion about patient care? Also under the umbrella is kink-oriented services. So dominatrixes, doms, doming, professional submissives also. So when we're discussing sex workers from a healthcare standpoint, it does them a disservice to paint them with a broad brush. And I put a little graphic so y'all don't get bored. Different types of sex workers have different needs, not only in terms of the services and support they may need, but also in the way they are carried out. They may face different levels of stigma, danger, etc., either personal or institutional. Someone who has a low level maybe of stigma day-to-day in their work, let's say like someone who doesn't face a lot of backlash from friends or family. Everyone knows that she's a stripper, she's a cammer, she keeps people around her that support her. It may be very shocking to be discriminated institutionally, especially if you have like a supportive network. And vice versa. If you have support institutionally and don't have it outside, how do you gain that? How do you transfer that out? And so what are the different needs in patient education? So for street-based sex workers, they may face higher exposure to violence, unstable housing and policing, increasing the need for harm reduction services, mobile clinics, and trauma-informed care. Going out to them is important, right? But how do we do that without going in and saving them? How do we go in and say, don't worry guys, we got you, just get in the van. Hold on. It's a very specific type of patient education that is required there. If you pull up with a red van, it's great if they know what it is, but it's also like, why do you want to take my blood? Like, what is going on? I charge extra for that, but it's, it's stuff like that, where it's like, it is a different type of patient education. So if you're going out into the field, it's very different than when people are coming to you willingly and seeking healthcare, right? So indoor or online sex workers, which I don't categorize usually in the same category, but indoor meaning someone who may work for in-calls, like clients come to them, either in their housing or somewhere that they go. This may constitute things like what's classified legally as brothels, or it may also involve things like you hear touring, right? I'm going to a hotel, you can book me here, etc. So that's an indoor sex worker in terms of what we look at in terms of research, right? And then online sex workers. When people hear online, they usually think about like advertising online or getting clients that you meet in person online, but that's not what I'm defining it as. This is a person who might be camming, might be creating pornography in the digital world. So they may need more support around mental health, right? Isolation, burnout, things that are not discussed usually in terms of that sector of sex work. And also digital safety, privacy breaches, doxing, protecting your anonymity and confidentiality. Legally speaking, and in terms of healthcare, it's so important if you see someone's legal name, right, and they disclose they're a sex worker, to continue to respect their confidentiality in that way. Online creators, legal gray area in much of the Nordic countries. What's allowed, what counts as porn, what doesn't. And it's often like, oh, well, we know it when we see it, but I don't think that's a good enough definition, personally. What are you seeing and knowing? I need the words, And so they may not experience as much physical contact or physical risk as others, but they still deserve patient education and social support in terms of digital harassment and stigma. But also keep in mind, they may be less anonymous in healthcare settings, especially in small countries, small communities, rural places in Scandinavia, right? Well, we all know, like we've all seen her Twitter. How does that change how you interact with the patient? Because it might. And how do we observe that and move forward and move past it and kind of like, I'll deal with that later and continue to do what you need to do. Erotic massage providers, also, and intimate service workers. So this is someone who, we hear things like rub and tug, massage parlor. They're not always migrant workers, but it's something that's usually like conflated with migrant work. So they may require guidance on musculoskeletal health, right? Hand and wrist injuries, safe touch practices, being able to visually cue, genital warts, HPV hand and foot warts, things like that. These are real things that they deal with, that they should be allowed access to and educated about. And then for full-service sex workers, having ongoing needs for, of course, STI testing, which is like always the focus, contraceptives, right? But also sexual health counseling that is stigma-free. What's going on with your pelvic health? What's going on with your, like we mentioned, like the arousal fluid, right? Bartholin's glands, things like that, urinary tract infections. And how do we get to a point where you are safe and consistent with your healthcare seeking? Trans and gender diverse sex workers also often face compounded stigma, and they need providers that are trained in gender affirming care, hormone management, but also respectful communication about their anatomy and sexual practices and their autonomy. This is also a big one. It's like you're either the specialist, the hormone specialist, the gender affirming healthcare specialist, but it's like, are those people receiving the same sex work training as, So there's a lot that has to kind of go across the board there. And of course, for migrant and immigrant sex workers, there's things like language barriers, lack of proper insurance, fear of deportation, so they need a different perspective as well. So end demand, what we hear, like the Nordic model, the Swedish model, I prefer to call it end-demand policy because it's also in places like Canada. And I'm not here today to specifically promote one policy measure over the other, but I'm going to approach this the way that we do in healthcare and health sciences, which is my background, which is this is the system currently in place, which means individuals are being impacted by it currently. So we know this is happening, so we have seen this is the result. And how does this system impact people's health and healthcare seeking behavior? So for criminalization, right? Of course, we see with certain end-demand policies, we do see an increased risk of violence and sexually transmitted infection. That can be sometimes surprising because in theory, right, if you are criminalizing only one side, then the other side should be free to gain the healthcare access and free to disclose, right? So what's happening? But the reliance on criminalized clients makes sex workers more susceptible to dangerous conditions. You are essentially telling people, you can do what you want, but you have to be economically and physically reliant on people who are engaging in criminal behavior. It doesn't sound great from a healthcare point of view, because people are often reluctant to disclose criminal behavior of themselves, but also those around them, for various reasons. But one of them could also be due to the client protecting their anonymity. What lengths are they willing to go? So cash transactions also are often a part of anonymity. You can't really like Venmo the sex worker, so you have to pay in cash. People know that the sex worker, the indoor sex worker, probably has a lot of cash. They become a target for theft and robbery. Working in undisclosed locations. I don't want anyone to know where I am. I don't know where I want anyone to know how to find me because I'm seeing a sex worker. I don't want anyone to see me. I'm in a small community, so we have to meet in this place that's like a downstairs apartment, and then you make a left turn, and then that's where I'll be. There's no windows, there's no cameras, but trust me, it'll be fine. So that's like the undisclosed location part of it. Like, obviously, the person committing a criminal act here doesn't want to be seen or caught. They may fear the police raids of clients, etc. An overall client demand for anonymity means less screening for identity, transaction safety, and STI status. They can't ask for an ID. They can't ask for even maybe a real first name. So how are they supposed to report a person where they can just kind of describe what they look like? It's not a good measure for public safety either. And in some contexts, criminalization leads to reduced usage of condoms because they have more power over a person. They might extort them or blackmail them to protect their anonymity in order to exert power over the sex worker. And so as a result, it increases risk of sexually transmitted infection. And sex workers themselves may fear police raids, even if part of, okay, Lysistrata. And so they may fear police raids for client busts or trafficking busts, right, still. So they may work from undisclosed locations of their own volition. So this means they don't have proper safety measures, and the fear of police in these raids may also inhibit them from reporting assault or violence because they may have very healthy, safe working condition. When something happens, they can't report it, and so where do they go from there, right? Earlier, we discussed intersectionality, so for migrant workers, this is also especially dangerous. But for my fellow public health nerds in here, both the World Health Organization and UNAIDS, which is a UNICEF sector, have endorsed full decriminalization of sex work as a part of measures to end HIV and also other sexually transmitted blood-borne infection. That's big. That's a big one. Because for us, there is a narrow focus, obviously, on like what's going on in the vials, what's going on in the lab. And so for us, having these endorsements is very big deal because they're saying not just out of vibes, right? We're saying it because there's a mountain of evidence that supports HIV transmission risk is lower when people have safety, autonomy, and trust in a healthcare system to not be stigmatized. So for migrant workers, this was a great quote I came across in this Canadian research. Migrant sex workers in particular face increased risk of violence and condom refusal from clients who assume they have less control over terms of service given their migration status, language barriers, and fear of police. So in Europe, especially moving across the Schengen zone also, we kind of lose track. Someone's here for 3 months and then they leave and then they might come back. We're not sure, what are they doing here? How do we keep track of them? There's a huge population of sex workers where we don't have really any data on. We don't know what's going on with them in terms of STIs. We don't know what's going on in terms of autonomy or mental health, because it's very hard to keep track of what they're up to when they're here, which is a great system for a lot of other things. But how do we reach them when they come into the country? Do we have to then audience segment? Like, do we have to be like, hey, she looks like a hooker, come over here. Like, what do we do, right? It's important to keep that then across the board. Who is being trafficked also? What resources could they have? And what type of education and communication do we tell people when they come into the country? People often say, well, if we tell them it's legal for one half, then it'll just promote it. But listen, I'm from a country where there's abstinence-only education in the South. So I know that that's not how that works. But this is a really big one because migrant workers are especially at risk of both in terms of exploitation, but also in terms of even if they are here autonomously of their own volition, they may not be accessing the service because they don't know it exists. They don't know like they are allowed to go and get tested. They don't know they're allowed to disclose. Advertising also, so in different Nordic countries, this is why also calling it the Nordic model, I'm like, there's different Nordic countries have different policies about advertising. So when advertising is criminalized, sex workers lose the ability to clearly communicate boundaries ahead of time with like a paper trail, so to speak. Prices also and negotiation on services, forcing negotiations to happen in more rushed or unsafe context. The increase of, this also increases the likelihood of misunderstandings. It's just a misunderstanding. Or conflicts that can also escalate to violence. And restrictions of online or print advertising push sex workers into either unregulated or unencrypted platforms, making it harder to verify clients, like we talk about screening, and easier for people to exploit their anonymity. And criminalizing advertising also limits sex workers' ability in general to share screenings also and like share information online, especially in forums where they can come together and protect each other. So collaborating with peers is a big part of that too for reducing harm. And so we talk about client screening here, but there's an interesting part of this, which is like, well, end demand might be working. The client pool might be smaller, but consider who is willing to take the risks, right? Who is the person who is willing to continue to pursue this type of behavior, right? So when people say, well, the client pool is smaller, it's like, well, thought experiment, right? The people willing to take these criminal risks become the pool. Is that necessarily a good thing? Is it always a bad thing? I don't know. But client criminalization shifts power away from sex workers, forcing them to negotiate under pressure and often in isolated or hidden environments. And we know that. So criminalizing clients, it doesn't eliminate demand, right? But it drives it figuratively underground as well. So for stigma is something that impacts people of any sexual expression, right? We hear about slut shaming, all this stuff. But when we talk about like the moral assignment of sex workers, regardless of what form of sex work they take part in, there's also kind of a hierarchy within that, right? But it does impact people. And this is not to say, well, if you're a sex worker, you have low self-esteem or blah, 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 inherently because of the work that you are part of. It's not because you went into that work because you XYZ. It's more so that the stigma that follows and the stigma that is maybe mitigated at some point, that is what is contributing to poorer mental health outcomes. So their self-perception and mental well-being could be at stake. Their ability to gain emotional and social support from family, friends, and community. That's what we discussed earlier, right? Not everyone has that community that has their back. And their treatment by police and health and social service providers, right? And this is a big one because someone who could be outed as a sex worker may just suddenly lose contact with people that they thought were their community. And that is, we know in public health, a very high risk for mental health issues. So stigma in clinical practice, it could sound like this. She'll just be back next month. They're probably just seeking drugs. He must have low self-worth. He has an OnlyFans. These are things that could be thought of or said out loud during things like sexual history taking or mental health evaluation. Well, I mean, he said he was depressed, but I mean, we know like what he's up to, so it's probably because of that. Making assumptions why someone enters the work or how they feel because of it, not because of a sex worker's disclosure of those feelings, but because of things that follow stigma, which are stereotypes, and then, you know, that kind of precedes it, stigma, and then that leads to violence. So stigma leads care providers to make unfounded judgments and assumptions about sex workers' practices and lives, resulting in reports of disrespectful or paternalistic treatment. So institutional stigma also, right? In mental health care, stigma can cause providers to see sex work as the entirety of a client's identity, right? Every problem in their life might circle back to, well, it's because you do that in your free time. It's because that's how you make a living. Again, judgments about why someone entered the work or that they want to leave, or if they left, everything would get better, instead of actually focusing on the health problem or mental health problem, addressing the problem that you're seeing. It can obscure other important factors or underlying conditions for mental health, right? And ignorance or indifference to the harms of stigmatization and criminalization can also lead healthcare providers to fail to protect confidentiality. I talked about this earlier, right? If you know someone has an OnlyFans and they go by Bambi, but then you look and you're like, birgitta. And then all of a sudden you know. You know, like, are you going to say something? Should you say something? Like that's a position where some people find themselves in because they know if someone is trans, a patient is trans and they have a preferred name, they default to the preferred name. So is there a preferred name system for someone who's seeking confidentiality? It's a good question to ask, right? And then also healthcare systems in general tend to focus very narrowly on things like HIV, blood-borne infections, obviously because they're very important, but it kind of also neglects the other health aspects of sex work because HIV cannot be the only concern that we address, right? And then I'm not going to go through this too much, but structural marginalization. A lack of resources here in Iceland means like the police have openly said multiple times, like we don't have the resources to enforce and demand. So then that also leaves us with like, how is it working? Is it working? Like we don't have enough data and information to understand how it's impacting people positively. And workers are more susceptible to mental health challenges because of structural marginalization, like I was just discussing, not necessarily because of the work that they are a part of, but it's looked at differently than someone who, for example, works shifts, like healthcare workers, right? You're working 12 on, 12 off, multiple days in a row, 8 on, 8 off maybe. That's not great for your mental health. Anyone in here that's done shift work, I remember being so tired that I was just like, I don't know, like I can't feel my fingers. Not making great judgment calls, right? But I wasn't being treated necessarily for my anxiety and being like, well, you just have to quit your job, then everything will get better. It's like, that's not necessarily a treatment plan, right? You can make suggestions and recommendations about the labor someone is engaged in, but does it get to the bottom of like what they're there to discuss and be treated for? So in terms of harm reduction, the role of sex work harm reduction in public health is an important one. So as a public health practice, it refers to a range of intentional practices and public health policies designed to lessen the negative social or physical consequences associated with various behaviors. So it's just kind of word soup for saying making things safer without having to ban them outright, or telling people this is, if you're going to engage in this, do you guys remember the movie Mean Girls, where it's like, if you're going to drink, do it in the house? Like, that's a little bit similar to that. It's a public health practice, though, that really focuses on the health and safety of that person instead of telling them to abstain from the activity altogether. So, you know, we see it in other sectors, so like needle exchange programs is a harm reduction strategy. So for sex work, what does that look like? It's also for people that are perhaps unable to or unwilling to make this abstinence, right? That's kind of often like the way it's approached. But for me, in public health, harm reduction for sex work involves also tackling the area where it's like someone wants to do this. So how are we then reducing the harm institutionally? So it's like I'm reversing it. It's not just how do we treat this person to make sure they're making good choices, but it's also like how do we reduce the harm under a system that's maybe criminalizing people? How do we reduce the harm from that as well? So the tools for sex work harm reduction in healthcare, this is not just like all what I teach, but you know, in an ideal world, skills for recognizing internal bias and institutional stigma. How are you showing up in your patients' lives? How are you showing up in general? And then processing and communication tools for discussions on all sexuality, not just sex work, but someone's coming to you telling you, you know, they're having pelvic pain because they enjoy being fisted. What is your reaction? What's happening on your face? How are you reacting to that? Because how you are and how you're showing up does matter in patient education and communication. So speaking of, having the skills beyond contraceptive use and recognizing sexual abuse. Are you using a condom? Are you being hurt? There are other things happening there, and we don't have a lot of time often with patients, but I know for a lot of people, they are more likely sometimes to disclose to a nurse than the doctor because they have more time with them, especially in hospital settings, they're around them more often. And how do we use that to our advantage, right? Knowing when and how to refer out, offer resources, and the reporting process. So I have 2 more case studies, and they're gonna go a little quicker than the first one, but for a unit specifically on sex work, which I don't currently do, but I have in the past, I would include more specific examples about like client disclosure, like how do we react when someone discloses they're engaging technically in a criminal behavior? Is it similar to when someone discloses drug use? Or is it like, well, then this person is inherently abusive because that's the way it's set up. So do I have to report abuse? That's a hard one to sit with, right? Sex work involving kink, fetish, and BDSM, I would definitely include, and then also a patient disclosing details that lead you to suspect sex trafficking, but they're not willing to cooperate. Like, what do you do? Where do you hand that off to? And remember, with these case studies that I give my students, they're not to find like a perfect solution. I'm not being like, you are wrong for saying that to a patient. I'm telling them, get it all out. We're here to get it all out. And so when you see the student reactions, some might be a little intense or judgmental, but it's good. I like hearing that because then we can kind of dig into that and be like, I'm not telling you not to think that way, but these thoughts are going to come up, right? Harm reduction. These thoughts are going to come up. How do you differentiate between that and the care that you're giving? So the first one here, sex work and healthcare access. A 22-year-old woman mentions in passing that she engages in an undisclosed form of sex work to support herself. She seems hesitant to disclose details and asks if her records will remain confidential. I don't usually tell doctors this, she admits. So instead of the reactions, I'm going to show you some of the solutions that they came up with. Because remember those discussion questions from earlier? This was like kind of how they would move forward, right? The form of sex work makes a difference to them because her needs for care may differ. So how do you approach that? Do you fill in the blanks or do you ask outright? Are you allowed to ask outright? Ensuring her confidentiality and creating an environment for disclosure. right? Is it a rushed environment? Is she in the hallway with a ton of other people? Is it in a separate room? Asking questions that impact treatment, not only out of personal curiosity. I liked this because it's like, yeah, you might be like, oh my God, I'm dying to know what she's up to, but does it matter? Does it make a difference? Sometimes like in Iceland we say like, taka spjallið, like, with your nurse who's maybe doing patient education, you're having a chat, especially in like long-term treatment care, like cancer care, they may ask questions about what your relationship is like. What is your relationship with your children? What type of diet do you have, right? How does this fit into that? Observing their negative feelings and refocusing on the patient needs. I was like, yes, of course. Yes, thank you. Because, yeah, you're gonna have weird feelings, especially if this is new, especially if this is something you're not used to. You're gonna feel uncomfortable and scared, and you might not know what to do, and you might not know what to say, and you're like, oh my God, if I say the wrong thing, will they never return? It's a lot of responsibility. So being able to acknowledge and observe those is really important. So this is the last one here. So BDSM and consent, because they're not all as straightforward. A 36-year-old woman comes in for an emergency regarding her IUD being dislodged, but you notice extensive bruising and marks on her inner thighs and buttocks. She quickly clarifies, don't worry, they're not from anything bad. She mentions her frustration with healthcare providers in the past, assuming that her, quote, lifestyle is abusive. So here were some interesting reactions, right? Someone saying, hey, as a nurse, if I'm seeing bruising and bleeding, I'm gonna check it out. I'm gonna be asking questions, I'm gonna wanna look at it, I'm gonna wanna know, are you okay? And if they're frustrated, I don't care, I have to, there's marks on her. But what's most frustrating is what if she needed help in the past but was afraid to be judged? Because that's what, she was saying here. She is frustrated with the healthcare providers. The use of the word lifestyle raises a red flag for me, and I would want to clarify that. Like, I want clarity on that. Does she mean way of life, or does that mean way to make a living? Well, what would change if she got paid for it, but she still consented? Wait, do you think that maybe she endured it to get the payment? I'm not really sure how this works, to be honest. Don't we have to take her word for it? I guess we could refer her to talk to someone, maybe a social worker. I hear that a lot. Are we pathologizing her sexual pleasure? That was interesting to me too, because it's like, wait, maybe she is a sex worker, maybe she's a professional submissive, maybe she's a sex worker, sure. But also, like, maybe she's very kinky. This is just like one of those things where it's like, where do we go from here? How do we ask? What is important to know, and why is it important to know, and how does it change the care that we carry out? So for this one, I didn't put my solutions on the board here, but just having a safe disclosure environment is really important, but also being able to differentiate between like that curiosity versus what's actually necessary for patient communication. This is where we really see that reduction in stigma. What is important to really ask them for their safety, and what is just something you're wondering about? Making that distinction is really important to create an environment where someone feels safe to disclose. So there's some gaps in knowledge and resources. Again, refer out to a social worker. The social workers are under a lot of strain. And also people are not sure when to refer or how to refer out, right? There's also a lack of clarity, unsure what to do if someone discloses sex work status, either as a provider or a client, and what patient support is needed, right? And then inner conflict. They need tools to process shame, guilt, responsibility, and anxiety. So healthcare providers can play a huge role in creating a safer, more equitable healthcare system for sex workers. And they want to. I hear them. But they're not sure how to proceed. They're not sure what to do. The language is so vague in a lot of the laws and a lot of the healthcare education that it can be very difficult to know what to do. When do I refer out? Do I just automatically ask everyone if they're being abused? There's a lot of questions about that. So looking ahead, training clinicians in bias recognition, trauma-informed care, easier said than done. but important nonetheless, and engaging with sex workers to inform policies that reflect the diversity of their realities and their needs. Because it's not only about indoor sex workers, it's not only about people engaging in what we call vaginal, oral, anal, sexual contact. It's not only about the migrant workers, right? There's so many different facets of sex work, and how do we create systems that cater to a broad range of needs, but also individually unique needs, right? And then implementing policies, again, I'm not a policymaker, but in analysis, we can say that it would be important to see things that support access to services and resources, preserve confidentiality, and respect the agency of those engaged in sex work. If they tell you they don't want to quit their job, how do you move forward with that? If they tell you they're happy, why are we not believing them? And developing programs that promote sex workers' security, health, and well-being. Here's some references, and if any of you want some, listen. But I do have questions or resource requests, and if anyone needs those references, I'm happy to share them. But thank you so much for listening and for your attention. I know some of this is dense and jargon heavy, so I'm very happy to have your attention. And also for you guys to get a little taste of what I do in class and go through some of these case studies. So thank you. And if you have any questions or comments, feel free. But you can also catch me later outside in the hallway. I'll be here all day. All right. Thank you so much.